Okay, welcome everybody. Thank you for joining us. We're the British Caribbean Doctors and Dentists Association, and our event today is all about learn about lupus. So my name is Dr. Stacey Bryan, and I'm Vice Chair of the British Caribbean Doctors and Dentists Association. I just want to spend a few minutes just letting you know about what we're all about, basically. So we were set up in November 2019 by our chair, Dr. Rochelle Pierre. And it was a way of getting together doctors and dentists of Caribbean heritage together just to kind of support each other through our training, through our journey through medicine and dentistry. Now, we have since grown, and there are multiple things that we're involved in. Firstly, we have a professional development arm. So this is where we support and mentor budding medical students, dental students, as well as doctors and dentists in training, supporting them all the way up through into their training and into consultant level. We also have a research team that are looking at statistics involved in how many people are actually entering medicine and dentistry and seeing what we can do to try and improve that. We work with young people and schools, primary schools, secondary schools in the community as part of our outreach team. And this way we try to hope to raise the aspirations of our young people in our community to hopefully enter degrees in careers such as medicine and dentistry. And that's through our outreach program. And lastly, we're a strong believer in increasing the health literacy within our community. So we know there are a lot of medical issues that affect our communities, and we really want to try and kind of present or give a platform for you to be able to kind of understand some of these a bit better. So if you do have a problem and you're going to see your GP or a specialist, for example, you would understand some of the terminologies that they use. But also, we're really keen on trying to bridge the gap between us as healthcare professionals and you as the community who are seeking our help as to how we can better improve things and being your representatives within healthcare. We are at the moment applying for charity status. Of course, everything that we do, unfortunately, does come with a cost. It does need help to do so. We will be sharing our social media and some links in the chat as to how you can follow us. You can send us some emails, give us some advice. And of course, if you would like to make a small donation to our association in order for us to continue to do what we were doing, then we'll be very, very grateful, and any amount will be appreciated. So I hope you enjoy this event this evening, all about lupus. We have some fantastic speakers. I won't say any more, but I will hand over to our host for the night, who is Dr. Darian Richards. Thank you.
Hello, good evening, everyone. Thank you for joining us this evening to learn about lupus. So we've been joined by three fantastic panelists who will be walking us through different aspects of lupus. Now we have Mr. Karl McPherson, who will be our first speaker, will be giving us some information about his journey. Then we'll also get to hear from Dr. Ronnie Cooper and Dr. Gerald George, who'll be going through both the dermatological and rheumatological aspects of the disease. So how the session will work, I will introduce each speaker and they will each in turn give us a presentation. Following that, we'll have a period for questions. Now, if you have any questions that you'd like to ask, please put them in the chat. They'll be filtered to me and then I will ask them on your behalf. If there are any last minute questions, and once we get to that point, if there's time, we may have the opportunity for you to ask further questions then as well. So first of all, before I continue, just the basic ground house rules. Obviously be respectful, whether that's in the chat or if you are speaking or get the opportunity to speak. And this covers things like not being sexist, racist, homophobic, or any behavior that wouldn't be tolerated generally. We all want to be respectful and loving, and we're all here to learn and get a greater perspective on lupus. So if everyone, from what I can see, everyone is pretty much already muted. If you could remain muted throughout. This event is being recorded, so if you don't want to be seen or heard, please remain on mute and with your video off throughout the duration of the event. So The first person we'll move on to now is our first speaker, Mr. Karl McPherson. Now, he has experienced symptoms of an autoimmune condition quite closely related to lupus, with an overlap with the mixed connective tissue disorder. He works as an obstetrician and gynecologist, and his key area of skill is fetal medicine. Now, he lives and works in the Northeast, but trained in London and Glasgow, and is a married father of three who, in his spare time, raises money through a series of endurance sporting events for a charity called Tommy's. So there's a link that should be in the chat or the bio for his fundraising. Essentially, this is a charity whose goal is to make pregnancy safer for all and advocates for supporting those who have lost babies, unfortunately. So it's a great charity, great cause. So if you would like to check out that link, that would be greatly appreciated. So Mr. McPherson, over to you.
Hi there. I just wanted to say thank you to Darren and to Stacey and to everyone within the BCDD who have chosen me as someone to kind of speak to this audience. I thought I would primarily speak as a quote unquote patient, although you'll be aware that my background is medical, and so I guess it's very hard to divorce the two. There's always going to be a little bit of crossover between my understanding as a patient and then also my understanding when it comes to my clinical area. So I thought I'd start off, first of all, by talking about what this condition means to me. The challenge is to really give it a name. So you'll find in many instances that because the symptoms and signs that can be associated with lupus are actually quite big and quite broad, it can oftentimes be very difficult to actually pin down exactly what we're talking about. And equally, it can be very difficult to sort of tease out what one person's experience of lupus is over another's. So my story with this condition starts off long before medicine. And I had a close family friend who we'd known kind of for years, who had the condition, and all I understood of it was the word. And in fact, not entirely dissimilar to me, the only external features was the discoid lupus appearance in her scalp, apart from some of the things that she spoke about and complained of. And she went on subsequently to have some issues with blood clots and went on to have 3 strokes in later life, years down the line. And at the time, we then came across another family with another lady who was affected by the same lupus condition, who again, her manifestation was through strokes. And this was when I was maybe sort of 15 or 16. And it suddenly became really clear to me that actually that these Black women were unusual in the sense that I'd never come across anyone who'd mentioned this before, and yet here were 2 people in my social circle who had skin like me, who were having the same kind of problem occur. Anyway, flash forward to when I am about 33, and at the time I had quite long hair, and I was just kind of at a family barbecue, and someone was having a look at my hair and was messing around with it, and happened to notice a bald spot in my head, and said, "Oh, have you noticed that you've got a little bit of hair loss?" And I said no, because it's, you know, in the middle of my head, and I had, as I said, I had quite a lot of hair, and I'd completely been oblivious. Now, the 6 months before that, I had developed Raynaud's. And for those of you that don't know, Raynaud's syndrome is a condition whereby you get vasoconstriction. So the blood vessels in my hands and in my feet will often almost entirely cut off the circulation to my digits. So oftentimes the first time that I know that that's happened is actually when I've actually lost nervous control. So your nerves are quite sensitive to a lack of blood supply. And so oftentimes I will find that my hands are immediately sort of numb, or I've lost power in my hands, or things of that nature. And this had been happening for maybe sort of 3 to 6 months beforehand. And on top of that, I'd noticed that I'd been getting swollen legs quite a lot. At the time I was cycling to commute. And at the end of all my bike rides, I would quite regularly find that I was getting sort of pitting edema up to my knees. So I was retaining water in my legs, which kind of made no sense at the time. And then the addition of the bald spot, I didn't realize at the time that these were all starting to sort of fall into place as to having developed an autoimmune condition. In fact, somewhat foolishly, I had misattributed my own personal, so another symptom is also bizarrely sort of susceptibility to bacterial and fungal infections. So at the time, I'd had a bout of athlete's foot that I was really struggling to get rid of, and I had just assumed that maybe I had a fungal infection transfer to my scalp. And at the time I was living down south in London. I moved up towards Glasgow again, and after repeated doses of sort of over-the-counter antifungals, I was finding that actually I wasn't able to shift this bald patch in my head, and it was itchy, it was painful. I went to the GP who did a series of bloods, and they found that actually I had an autoantibody, and I was neutropenic. So in other words, my white cell count was low. And so it was starting to look like there was something in the background. So at that point, I was referred to a hematologist, and I was referred to a rheumatologist. And the stuff with the scalp had been, unfortunately, misinterpreted as a pus generating infection, sort of skin condition. And so again, I was treated with antibiotics, not what I ultimately needed, which was steroids and other forms of immunosuppression for my scalp. And effectively, what would happen is they would check my bloods, they would find that my white cells were low. You know, at the time I was cycling quite a lot, and so I wasn't desperately keen to go on any nifedipine, which is a drug that sometimes is used for Raynaud's. It works predominantly to lower your blood pressure, but the byproduct is better perfusion through your extremities. So can be used as a means of trying to reduce Raynaud's. And because I was training, I was particularly keen on avoiding things that would lower my blood pressure, simply because I was worried about being a long way from home, and you know, maybe my blood pressure dropping and that kind of thing, and putting me in a vulnerable position. So then that process really took another 18 months. And it was only when I moved here to Newcastle and had a new dermatologist that he said, look, I think they've made completely the wrong call on what's going on in your scalp, particularly as it relates to what at the time was an antibody that isn't classically associated with lupus. So I have an anti-centromere antibody, which is more related to either mixed connective tissue disorder or systemic sclerosis, which are two other autoimmune conditions. They don't seem to affect those of us of Black descent or African descent in quite the same way. But that was the picture that I had. So I was having these repeated blood tests, and effectively what would happen is, at the moment where I had chest infection, which I'm quite prone to bronchitis and latterly now UTIs, my white cell count would go from sort of 1 to sort of 6, and then they would say, well, it's normal, we can discharge you. And I would say, well, actually it's not normal, I'm actually unwell, you know, I have a temperature, I think this is an enduring sort of problem. And this dermatologist was a person who kind of turned things around for me, because he chose to do a punch biopsy of my scalp and was able to demonstrate that actually the skin condition was discoid lupus. And once all of that was tied up with the rheumatologist here, it became far more apparent that this was a version of lupus with some overlay of mixed connective tissue disorder. And I guess since then, what I personally have tried to do is try to be really sensitive to my own body and try and figure out exactly A, what my symptoms are, and B, what changes those symptoms. So for me, the one of the biggest problems I found, once this was discovered, I was given steroids for my scalp, and my scalp calmed down almost immediately. Within a month, I was no longer scratching, and no longer had sort of red flakes. Effectively, this autoantibody is focused on some aspect of the skin in my hair, and so would literally cause destruction. And actually, at the time of kind of finding all of this out, what I was noticing was that actually it wouldn't take very much for huge chunks of my hair to kind of fall out. Like I'd walk past someone and brush their coat and it would pull, and that would take a whole section of my hair out. Or there was a day I'd kind of walked through a wooden door and caught my hair on the door and lost another section of hair that way. And so in the end, I made the decision to cut my hair. But I think one of the challenges is that so often people kind of have their own assumptions as to what's going on. And that really kind of clouds judgment. So a lot of the times people are saying, look, this is because you've grown your hair long or whatever, not realizing that actually the skin condition itself is entirely sensitive to ultraviolet light. And so basically my hair was actually protecting my scalp as long as I had enough hair to cover the patches. And effectively that kind of disappeared with time, which was quite difficult. And I think one of the hardest things about this condition is that the bits that are unseen, so the regular infections and the kind of feeling generally unwell, I'm very fortunate. I have very little by the way of recurring episodes of joint pain. I certainly have no kidney involvement, but I'll come back to the kidney story in a moment. But one of the sort of challenges is that most of it is unseen, and that which is seen is actually pretty unpleasant. So for me, it's taken probably more than a year to really accept that this is now my appearance. I will not live beyond this point without a scarred scalp. And just to show you what I mean, I'm just going to tip my head so that you can actually see the rash in its entirety. So it does take up quite a lot of the surface area of my head. If I go more than 2 or 3 days without my medication, I kind of refer to it as feeling like fire ants are crawling on my scalp. But effectively, all the rims itch intensely, they swell, and then I get these red flakes, which I assume is on a kind of small level, kind of blood as the sort of hair follicles are destroyed. And this is a form of a scarring alopecia. So I will almost certainly never regain full hair in these sections of my head. There may be some resolution to some of these smaller spots, and more latterly, you can probably see here where the new ones are starting to come in. So it's been a real challenge to kind of have to live as someone who doesn't have hair, and I can only imagine this would be worse for women because and it's one of the reasons that I deliberately keep my hair very low is so that, you know, the native skin and the scarred skin doesn't look quite so stark as when I actually have my hair any longer, and you can kind of see the color of my hair, and then you see the difference between where there is and there isn't any hair at all. So ultimately, the steroids and things have helped me. Equally, learning to be sensible, and I was kind of really stuck at one point with my treatment because I wrongfully had kind of decided that I didn't really want to use sunblock on my head every day. That kind of felt unusual, abnormal to me, and it wasn't something that the dermatologist had suggested. And so this year I've kind of made that choice to use an oil that would actually not be visible, because one of the things is, oh, for me anyway, is the notion of kind of walking with that kind of sunblock patch on my head. And again, that produces its own problems with the endurance sports and things that I do, simply because when you're outside, you know, you're getting huge amounts of sun exposure, and where I had the hair, I was somewhat more protected than I am now. So it's those kind of decisions that have been quite useful in the long run in terms of managing my own symptoms, above and beyond the medicines that that I use, which are typically a high dose steroid, which at the moment I'm still using 1 to 2 times a week, and I'm also using daily the sort of tacrolimus ointment. The fundamental problem with the steroid is that it causes skin thinning. So if I use it for sort of chronic purposes, effectively I will run into problems again. And then I was started on hydroxychloroquine, which for most people is actually really, really well tolerated. For me, I personally found that it coincided with a bout of kidney failure, which is very hard to prove as a kind of causative relationship. But again, it was about, for me, the whole journey has been about trying to be sensitive about how things manifest for me and what I think is sensible versus not. And ultimately, you know, my scalp was no better with the hydroxychloroquine when I was at my most diligent with it. And for me, I guess the idea of suppressing new lesions kind of 4 years into this has been less important, shall we say. So I guess the other point there is that, you know, I don't monitor my white cells, but I do know that I have problems. So for instance, last week I went for a swim, ended up with a bout of sinusitis that left me pyrexial for 3 days. And so again, I've learned a little hack in the last week of how to maybe prevent that. So one of the things I now do is I now do a nasal rinse after every swim. And so far that seems to be working. And actually the stuff that came away clearly was part of that infection when I've done that. And so it's very much, I see myself as my own project, because you'll struggle to find good evidence base to a lot of things. What you will find, however, is that there's a lot of common stories out there. So you'll find a lot of common stories saying things like, you know, if I make poor dietary decisions, then I'm more likely to have a flare. And equally that, you know, at a certain point, systemic therapy is really, really necessary. I'm very fortunate in the sense that my disease pattern, they've been asking the question of methotrexate, but no one's ever really crossed a line with it yet, because effectively my symptom burden is actually, aside from my scalp, relatively low. So I wanted to quickly touch on some of my experiences as a doctor with this condition, because actually one of the useful things has been in knowing about it, because actually it has a fair impact in pregnancy. One of the things that I find that my colleagues are less aware of is that aside from the fact that you can have these two antibodies, anti-Ro and anti-LAR, that seem to cross the placenta like all antibodies do really readily, and they cause a 1% chance of bradycardia for the baby. So the baby ends up with a congenital heart block, with, depending on the time frame that it happens in, can sometimes result in high drops and death of the baby in utero, or delivery with pacing kind of immediately after birth for the most affected cases. And there's that aspect of it that's really well recognized. I think what some of my other colleagues fail to recognize with lupus is that actually, as a disease, although we measure certain antibodies, actually there's a whole range of antibodies that occur that we have never identified. for instance, the antibody that seems to be driving the discoid lupus that I demonstrate, and occasionally the malar flush that I demonstrate. And actually what we find is that these women experience antibodies that are a whole host of things that sometimes focus on the placenta and sometimes cause the baby problem, even though the mother is relatively asymptomatic. So I've had a case in the last sort of 6 months of a young lady with this condition whose predominant symptom is lupus. She's young, slim, fit, well, very physically active. And actually, she ended up with a sort of severely growth restricted baby that was delivered at 36 weeks with fetal distress at certain points relatively early in the labor. And again, it's really important, I think, that clinicians are aware that, particularly for the women who are of reproductive age, they need to know that actually, you know, lupus is really important to pregnancy. And if you've had a flare in the last year, in the last 18 months, it's probably reasonable, depending on the lady's age, to defer pregnancy for a little bit, because actually one of the difficult things is if you get a flare during the pregnancy, because again, your hands are somewhat tied in terms of the treatment options, which I think will be touched on in a moment. Because really you've got steroids and it gets a little bit limited thereafter. And I guess the other thing is just thinking about the neonatal status as well, because these babies often will have this sort of mixed bag of antibodies across the placenta, and the babies can often be born with features resembling lupus as well. I'm fortunate enough not to have come across a baby that was really severely affected, but you do see it in the textbooks as well. So with that said, I think I'm probably going to bookend things there. I hope that that has, at least in some ways, enlightened experience on what a mild case of something resembling lupus is like.
Thank you ever so much. So we're going to move on to our next speaker now. And our next speaker that we have is Dr. Ronnie Cooper, who's a consultant dermatologist who has worked for many years, both in the Caribbean and in the UK. And he has a wonderful motto, which goes, "Medicine gives years to life, but dermatology gives life to years." So without further ado, we have Dr. Ronnie Cooper.
Okay. Hi, everybody. And I just want to say congratulations to the organizers of the British Caribbean Medical and Dental Association for the great work they're doing, both to educate doctors and to try and help young people to join the medical fraternity. I was very impressed by my colleague who spoke before, that's Dr. McPherson. I could listen to him for a much longer time, because it's not, we as doctors often don't realize that we could be patients as well. So he has been on both sides of the spectrum, and I think that will make him a much better doctor, because being involved in obstetrics and gynecology, the women who get pregnant can have other diseases too, and this is one of those that can impact the outcome of pregnancy. So I was very impressed by his presentation and being aware of his own, vulnerability as far as diseases go. And my talk is about discoid eczema, because I'm a dermatologist. And of course, he touched about the subject of his hair and what it has been doing to him. And so I'm going to speak about discoid lupus. Now, what is lupus? Lupus erythematous is a condition that affects the immune system. It can cause problems with your skin, with your joints, with your kidneys, and other organs. Your digits, as my colleague referred to earlier. And discoid lupus, or otherwise called DLE, is the most common form of cutaneous lupus. It is characterized by scaly discoid plaques that can occur on the scalp, face, and any other part of the body. It may cause pigmentary changes, as we saw in his scalp, scarring, and hair loss. It can appear as a non-healing lesion on any of the sites that I mentioned before, and a biopsy is usually needed to confirm the diagnosis. But as he said, he went from specialist to specialist, doctor to doctor, and nobody suspected lupus. And that's the most important thing, is that unless you suspect lupus, then you can go on treating people, and the longer they have this condition, the more scarring they get. If you pick up lupus early, you may be able to minimize the hair loss, minimize the scarring, especially when it's in the middle of the cheek. You know, it's very embarrassing to have this scar that nothing can be done about. So early biopsy, early recognition that this needs further investigation is important. Now, who gets discoid lupus? It can occur males and females of any age, and it's 5 times more common in females, and typically affects people between the ages of 20 and 40. It's more common in people of darker skin, so we're more prone to get it, and it's more common in smokers. What causes discoid lupus? Some people think there may be a genetic predisposition. So in other words, if somebody else in the family has it, you can get it. Exposure to sunlight. And of course, if you have it, exposure to sunlight can actually make it worse. Some people think there might be a hormonal component that contributes to it, and toxins such as cigarette smoke. So these are environmental factors that can predispose to lupus. Now, what does it look like? Now, this is on a limb. You see how scarred it is? You see how scarred it is? Sorry about that.
Hello, we are not available now.
Sorry, Dr. Cooper, you're currently muted at the moment.
Okay.
We can hear you now, Dr. Cooper.
Oh, you can? Okay, I'm just trying to get my slide to move on. Okay. All right, so you're seeing the different parts of the body that you can get lupus. And of course, your face is what everybody sees. So this is just to show you, you can get it on your chin, you can get it on your cheek, you can get it in your scalp. And of course, as we saw before, how widely it can be spread on the scalp. And those areas are not going to regrow here. And of course, in a woman especially, this is very, very distressing for them. How do you treat discoid lupus topically? Meaning, what do you put on the skin? Topical steroids. As my colleague said, steroids are the lifeline of treatment with lupus, whether systemic or cutaneous. So topical steroids, usually potent steroids, and sometimes we have to give intralesional injection, which means inject the steroids into the actual lesions. And sometimes we use topical non-steroidal anti-inflammatory creams like Protopic and tacrolimus. Those are the two non-steroidal anti-inflammatories. What is the outlook for somebody who has discoid lupus? If picked up early and treatment started, then scarring may be avoided. Sun protection is very important daily. Sun cream, protective clothing, and sun avoidance. A very small number of people can develop squamous cell carcinoma at a site of chronic discoid lupus. So if somebody has discoid lupus in their scalp, for instance, and they notice that the area starts to have a small growth or starts to bleed, then it's important to refer them to a dermatologist, because squamous cell carcinoma can, in fact, if not treated early, can spread and kill you. That is, of course, is very rare, but it can happen. And follow-up is very important. What is the oral therapy for discoid lupus? There's hydroxychloroquine, which was mentioned before. There's systemic steroids. Then, if it's severe enough, then there's methotrexate, mycophenolate, acitretin, dapsone, and azathioprine. And I think my colleague who comes after Dr. George will touch on those, in that the people with systemic lupus tend to use more of these, the oral therapies. In summary, discoid lupus is a serious but not life-threatening skin disease. If you have a non-healing lesion on your skin, go and see a GP. But then at the same time, the GP must be aware of the possibilities. GPs have a very difficult job in that they have to know a little bit about everything. But this, if you have a non-healing lesion in your scalp or on your face and you try 1 or 2 creams and it doesn't work, then refer them to the dermatologist. So on this note, I'll say thanks for listening, and I'm happy to take any questions you may have.
Thank you ever so much, Dr. Cooper. So as I said before, anyone who has any questions, as some of you have been already, please feel free to add them to the chat, and we will present them shortly. So moving to our third speaker, Dr. Gerald George. So essentially, he qualified at medical school in Southampton and is an independent consultant rheumatologist and physician with 21 years of experience working in the NHS. He's currently a lead clinician of the rheumatology department and clinical director at Medway Maritime Hospital in Kent. He's a fellow of the Royal College of Physicians and is also an examiner for the Royal College as well. He treats all aspects of rheumatology and has published, many academic journals and publications on rheumatological topics. So without further ado, welcome, and we look forward to hearing from you.
Well, thank you very much. Can you hear me okay?
Yes, we can.
Good, excellent. Well, thank you for inviting me along, and thank you to the 2 previous speakers for highlighting various aspects of lupus. I was told there was going to be a lay audience here, so I've tried to cut out all the jargon as much as possible. But I will just share my screen, hopefully, and let's choose that one. And right, oops, we're at the end. Okay, so I titled mine Recognizing Lupus. And one of the issues about lupus is it can present itself in lots of different ways, and it can take a long time, as you've heard, for the diagnosis to be made eventually. So just a little bit of background, you've heard already. Now we call it lupus for short, but essentially the full name is systemic lupus erythematosus, or SLE. And it comes from lupus comes from the phrase wolf, Latin wolf, because it's supposed to be either a wolf mask or the wolf bite, which is represented classically by a butterfly rash on the cheeks and affecting the nose. And it's called systemic lupus because it can affect lots and lots of different organs. So I will just talk briefly about each of the various areas that can be affected. You've heard already, it's a disease of the immune system, affects various organs. How common is it? About 1 in 1,000 people have lupus. So, you know, if you're at a football stadium, 50,000 people there, you know, you'll have 50 people with lupus. Some will know they've got it and others won't, because either it hasn't manifested itself fully or well, they just haven't been to see their GP because they've just thought their symptoms weren't anything much. And then it's about 2 to 3 times more common in the African Caribbean people compared to Caucasians. And again, it affects more women than men. So it's about 9 times more common in women. 9 times more common than in women. No, that's supposed to say more common in women than in men. Again, what's the reason? Probably hormonal, with a combination of genetic involvement as well. Okay, so now I don't know if you can see this okay, but essentially this is a diagram that just shows the various different organs that can be involved. Now, if you look at the top left, people have general symptoms: fatigue, lethargy, feeling under the weather. We've heard about fevers. Now, fevers could be because of infection, but quite often there's also no infection. And the problem with this is that those symptoms could be due to anything. You can feel lethargic if your thyroid gland isn't working very well. You can feel under the weather if you've got a touch of flu. You can have a fever if you've got an infection. It could be a urine infection, chest infection, flu, cold. And hence, it can be sometimes very difficult to make the diagnosis. But then there are certain characteristics that start to point towards the diagnosis. Now, we've already heard about discoid lupus. And lupus, if you look at the second one down on the left, can affect the skin and the hair. And classically, we've heard about the discoid rash, but the classic one is the butterfly rash on the cheeks. If someone presents with that, then you have to be suspicious of systemic lupus. Now, not everybody who has cutaneous lupus, in other words, lupus affects the skin, necessarily has systemic lupus. So they won't necessarily have all the other features of lupus throughout the body. So you can actually just have the cutaneous lupus, the skin lupus, without other features. Now, the other thing to say about this long list here is that although lupus can affect all these various organs, not everyone will have each organ affected. Some people might just have 1 or 2 features. Some people, if they're unlucky, might have 3, 4, or 5 features, and they might not all present at once. So you might have just the skin and hair to start off with. You might have a short period where your lungs are affected. You might have a period where your blood vessels or circulation are affected. Some features might come and go, depending on, depending obviously on the treatment you're on, or whether you're on treatment or not. So it can make the diagnosis quite hard to make. But if you start with, if you have the skin and hair affected, we've talked about discoid rash, butterfly rash. Hair loss is another common feature that would start to point towards the diagnosis of systemic lupus. So I've got another slide here. So now you can see that if someone presents like that, unfortunately I've got on the right side of the screen, see if I'll get it out of the way. Right, if you've got the full screen in front of you, you can see, now it's called a butterfly rash because you've got this area of the cheek is, and then there, these are the sort of wings of the butterfly, and sometimes the nose is affected. You can have other areas affected, sometimes the forehead, and sometimes, if I go on to my next slide, you can see that sometimes the lips can be affected. So you can just see there. In this case, I think topical treatment has been used, and there's a little bit of depigmentation going on there. Again, we've seen lots of pictures of discoid lupus in the hair and alopecia, sort of losing the hair. And if you present with that and other features, then you have to start considering whether this is systemic lupus. So if we come onto this list again, now another common feature that the patients present to us is joint and muscle issues. So joint pain, it can be with or without swelling. It could just be aches and pains that just are quite persistent, quite often worse in the morning. If you've got a condition related to inflammation, then quite often the symptoms are worse in the morning. You wake up, you're quite stiff, your joints ache, and it improves as the day goes on, but you go back to bed at night again and it all starts again. In the morning you wake up stiff. That suggests there's an underlying inflammation. But it can just be a background ache. Likewise, the muscles can be affected. Now, in some people, you actually get swelling, which is actually arthritis, as opposed to just the pain, which we call arthralgia. Now, if you've got arthritis, then the treatment we use is slightly different to if you just got arthralgia, in other words, you're in pain without the swelling. So if you've got somebody who's feeling under the weather a bit, you've got flu, you know that you get fatigued, and you've got joint aches and pains, but that doesn't mean you've got lupus. And this makes it, again, as I say, very difficult for people to start considering lupus as a diagnosis. But you've got to keep an open mind. So if someone presents with a rash and they're fatigued and they've got joint aches and pains, then you have to start thinking, is this systemic lupus? So this is just a picture of, oops, just go back again, sorry. A picture of someone who has got something called Jacquard's arthritis. You can see there's a little bit of what we call hyperextension, where the finger bends a bit more. There's a little bit of swelling around there with a little bit of redness in the skin as well. That thumb there is just slightly swollen. This is something called Jacquard's arthropathy, quite often associated with lupus because the tendons are more affected than the joints. And if someone presents with that, then you start thinking, okay, is there an underlying autoimmune condition? And by autoimmune condition, we mean you've got antibodies in your blood, which are the immune system that is there to treat infection, but instead of treating infection, it starts to attack various parts of your body, be it the joints, the kidneys, the liver, etc. So then we've already heard from Dr. McPherson about something called Raynaud's, and this is poor circulation. And it's not necessarily poor circulation all the time, but what happens is the blood vessels start to contract. They squeeze up, particularly in the cold, and that causes a lack of blood supply to the extremities, usually the fingers or the toes, and with that you just get blanching of the fingers, and then when you come back in to the warmth from the cold, you get the fingers, when the circulation starts to return, the fingertips go blue, and then when the blood really returns, they go red, and you get this what we call triphasic color changes. That's 3 color changes. You get the white, and then you get the blue, and then you get the red. And I've got a little picture here just to show you. So in extreme, you can see there's no very good resolution picture, but you can see that there is pallor or whiteness, and that's not pain. That's just the circulation not getting to the fingertips. You can see that virtually every finger is affected. Those 2 fingers are not affected. It doesn't have to affect all the fingers, but it can do. Sometimes it's just 1 or 2 fingers that get affected, and that's something we call Raynaud's phenomenon. Now, Raynaud's itself is actually quite a common condition, and there's 2 types. There's primary Raynaud's, because which quite often comes on in teenage years, where people they're out in the cold, fingertips get white, but they don't have any other symptom. And if you do the blood test looking for other conditions, autoimmune conditions, they come back negative. That's primary Raynaud's. Quite often, we sit up and take note if Raynaud's onset is in adult life. So if you're 30, 35, and then you suddenly start to develop Raynaud's, then you're more likely to have an underlying condition. We call that secondary Raynaud's, because it's secondary to an autoimmune condition such as lupus or rheumatoid arthritis or Sjogren's syndrome. Don't worry about the other names. But so adult onset of Raynaud's points towards an underlying autoimmune condition. So if we go back to this, now that, as I said, Raynaud's can present in lots of ways. So it can affect the brain. So sometimes people present with psychosis or depression. They might just have memory issues. They might have difficulty multitasking. And if that happens, okay, there are lots of causes for that again. So depression on its own can happen without it being lupus. But of course, if you've got depression and you've got fatigue, you've got a skin rash, and you've got joint aches and pains, then you have to start thinking about lupus as a diagnosis. It can affect the nerves, particularly what we call the peripheral nerves. That's the nerves to the fingers and to the toes. And that can present with numbness or a burning sensation in the fingertips or in the toes. That's nerves being affected by lupus. Now, if you're I shouldn't say unfortunate, but in some people, it can affect, if you just go onto the left side of your screen, it can affect the lungs. And it can present with chest pain, something called pleurisy. When you breathe in, you get a sharp pain. And that's because the lining of the lung is inflamed, and that can cause pain and be part of lupus. If it gets quite bad, you can actually get fluid in the lungs itself. And if you have persistent inflammation in the lungs, then you get scarring, something we call fibrosis. One common organ to be affected is the kidneys. Your kidneys there. About 50% of people have kidney involvement if you've got systemic lupus. And you might not know about it. It might just present with high blood pressure. But if you are seeing a rheumatologist or a doctor, what they will do is test your urine and look to see if there's blood protein in there, because that that suggests there's inflammation within the kidneys, something that we call nephritis. It can present with abdominal pain if the lining of the abdomen, the tummy, is inflamed. Again, blood tests will show high levels of inflammation, and the person might present with pain and inflammation. It can affect the heart. Again, not very often, but it can do, and it can be inflammation of the lining of the heart, something we call pericarditis. It can affect the muscle of the heart, something we call myocarditis, and it can result in fluid around the heart itself, something that we call pericardial effusion. Again, that is related to inflammation in and around the heart. And it's rare that someone presents with that as the first feature of lupus, but if they have got all the other symptoms or some of the other symptoms and present with shortness of breath, for example, or reduced exercise tolerance, then that's the sort of thing that one needs to look out for. It can affect your bones. Down here on the bottom right, if you've been on treatment such as steroids can thin your bones out, and if they're thin, then they can be susceptible to fractures or breaks, something we call osteoporosis. And another reason is, of course, you get vitamin D from sunlight. If you're avoiding the sun and you're on steroids, then what might happen is that your bones thin out and you get osteoporosis and you fracture. So, and finally, we talked about, or Dr. McPherson talked about blood count. You can have a low blood count, something called anemia, and you can have infections because of low white count, and you can have enlarged lymph glands. So the lymph glands you can find in your neck, sometimes under your axilla. Some people present with enlarged lymph glands. Okay, so you've presented to your GP. What are they going to do? I've kept it nice and brief. They're going to do blood tests, and the blood tests they're going to do are looking for evidence of inflammation, something called the ESR and the CRP. But they're also going to do some antibody tests, something called the anti-nuclear antibody. That's the first screening test. And quite often, if that's positive, that will point towards something going on. It just says there's something going on. And then there are more specific antibodies called the DNA and ENA antibodies. And they're various subsets of the ENAs which help us decide what type of autoimmune condition is going on. The DNA is quite specific for lupus. SM is quite specific for lupus. The others can have overlap conditions, mixed connective tissue diseases, Sjogren's syndrome, etc. But blood tests are a very good way of making the diagnosis, and it's essential the blood tests are done. Then they test your urine, as I mentioned before, for blood and protein. You might need a skin biopsy. We've heard about that already. They might do some X-rays of the joints or the lungs. That's an X-ray there. They shows they test with scarring, something we call fibrosis. This should be a nice confluent. It should be nice and even, but of course you can see there's lots of little dots and lines across there, and that's scarring in the lungs. They might do CT scans, they might do MRI scans. This is an MRI scan of a brain. There's lots of little dots in there which you might make out, and that's something called vasculitis, which is inflammation of the blood vessels in the brain. If somebody has that, they might present just with feeling lethargic, for example. They might present with depression or psychosis. And now most people, well, we're getting more and more attuned to patients presenting with such things. So, you know, it can be picked up on scans. And, you know, if you've got chest pain, you might have an ECG done. ECG is something that someone's got pericarditis, which is inflammation of the lining. So those are the sort of investigations that a GP might do, or if the GP's done the first ones and they're not quite sure, a rheumatologist will do. So what's the goals of treatment? I might just about have enough time to do this. Yes. The goal of treatment is to achieve something called remission, which is you're symptom-free and you're living your life as normal as possible with or without medication. Just because I've got a lay audience, I'll talk about non-medical advice briefly. Diet, there is no such thing as a lupus diet. A healthy, balanced diet, rich in fruit, vegetables, low in fat, and with proteins, depending on whether your kid is affected, the protein level changes. Vitamin D, as I mentioned before, because if you're shielding yourself from sunlight, you don't get the vitamin D. And if you're on steroids, you need the vitamin D to just maintain your bone strength. Be physically active as much as possible, and avoid the triggers of lupus. We've already heard about it: sunlight, smoking, stress. Those things can cause what we call lupus flares, where the condition worsens. It gets the immune system gets stimulated, and the condition worsens. You get more joint pain, more skin rashes, feel more lethargic, etc. Briefly about medication, again, because it's a non-medical audience, I just put a list there of things. Hydroxychloroquine, particularly if you've got joint and skin issues. We've heard that people don't always tolerate hydroxychloroquine. Steroids are good short-term, not a very good long-term treatment because they can cause side effects, but they work very well in the short term. Azathioprine, it suppresses your immune system, likewise methotrexate, so that it suppresses that part of the immune system that causes inflammation in the various organs, be it the kidneys, the heart, the lungs, or the joints. Tacrolimus is quite good for the kidneys and skin. Cyclophosphamide if you've got inflammation of the blood vessels. And then these are something called biologics, belimumab, that affects a part of the immune system, certain cells called B cells that are involved in inflammation. But the important thing is to take your medication as prescribed. One of the biggest causes of lupus flares is non-compliance with medication. People not taking their medication. The condition gets worse and they repeatedly come back either into hospital or get a worsening of their condition. So that is a 3-hour talk in 15-20 minutes, and I thank you all very much for listening.
Thank you ever so much. It was very informative. So now we're going to move on to the question and answer session. So how it will work is that I will go through a list of questions that have been proposed, and I'll try and direct them as I do that. So the first question that I have is for Mr. McPherson. So it goes, how did you feel about being misdiagnosed initially?
That's a really interesting question because my first instinct was to, once I realized that what was in my scalp was not fungal, I had convinced myself that the combination of the rash that wasn't answered by an infection plus the Raynaud's would equal lupus. Mm-hmm. That was only compounded with the sort of low white cell count, with the with everything else that was kind of going on altogether. I think the difficulty was a lot of the time people kind of were seeing it from their own individual perspective. So my hematologist was seeing the low white blood cell count in isolation. The dermatologist was seeing my scalp in isolation, and those kind of things. So there wasn't really anyone who, and again, the rheumatologist had seen the anti-centromere antibody and said, well, this doesn't really match the notion of lupus. So I don't personally feel sort of begrudged that I had a late diagnosis, but at the same time, I walked into each of those consultations saying, look, I think this is probably what it is. And the challenge is for all of us as doctors, how do we bring our patients in on that journey of decision-making, of making a diagnosis, and of treatment therapies? It's something that I find challenging on a daily basis you know, in my own clinical practice, and I would feel a bit of a hypocrite if I said that actually it's not it, you know, something was done wrong, or, you know, or I was ignored, or anything like that. Because I think on the one hand, you have someone who walks in through the door that, you know, picks the rabbit out of the hat and says, you know, this is this really abstract condition that is not really that common. And there are other explanations for Raynaud's, there are other explanations for alopecia or hair loss. There are other reasons to have low white blood cell count. So it's a particularly hazy area. And I think the worst bit for me is that I don't walk around with the big, you know, malar flush that's really evident to everyone else, you know, with swollen joints and, you know, a more severe sort of appearance of things. So I think I would have always been hard to diagnose. I think the punch biopsy is ultimately what did it.
Okay. And the second question also for yourself. So lupus requires a lot of adjustment on a patient's part, on your part, in your situation. How has that condition, however, impacted on your family and friends? Because there's obviously your own adjustment, and as the person experiencing it, and everyone else around you.
It's a great question, actually. So there was something that I had thought to say and didn't really touch on, was that actually it had a huge impact, particularly on my wife, at the point where things were still relatively unknown. So, and I think Dr. George might be able to clarify a little bit more on this, but actually, because of my anti-centromere antibody and its relation to systemic sclerosis, it's thought to be a sort of life-limiting condition. It's much more severe, but I have none of the phenotype for it. I have none of the appearance of it. So I don't have a tight mouth. I don't have any sort of problems at the angles of my mouth. I have no calcium deposits. My skin is still very stretchy. But it was something that my wife read up on Google and then had convinced herself that, you know, I had a sort of time cap on me. But I'll let Dr. George speak to this one, actually.
Yeah, so centromere antibodies are usually associated with limited scleroderma, which is a condition that can cause skin thickening, as you say, tight mouth as well. The mnemonic is something called CRESS, which is calcinosis, which is calcium deposits under the skin. Raynaud's, so the only feature you had was the Raynaud's. Sclerodactyly, you know, sort of tight skin on the scleroderma. Skin rash called telangiectasia, which are little capillaries on the skin, either on the face or on the back of the hands. Not very easy to see on dark skin, but easier on white skin. And then problems with swallowing, something called esophageal dysmotility, because the esophagus doesn't work so well. It used to be thought to be purely a benign condition, but we used to call it CRESS syndrome. We call it limited scleroderma now because it can sometimes progress slightly. Now, quite often, not quite often, but sometimes we find these antibodies but no features, just as McPherson saying. And it's difficult. I mean, I have had some patients that present with certain antibodies, and we go, well, but you don't have the features, and either time will tell, or actually, do you know what, you've got these antibodies, but you're presenting with other symptoms. Yeah.
Thank you. So next question, again for Mr. McPherson. So is there anything that you've changed about your medical practice since, you know, your experience as a patient? And with that, what advice would you give to doctors for their diagnosis or management plan, and how it might differ with their patients?
Yeah, so I guess I'll approach that two ways. So I'll approach that as a doctor who happens to be the patient, and I'll also approach it as a doctor who is in front of a patient, if you see what I mean. So for me, a lot of the time, I guess the challenge is that whilst this is not my clinical area, I have some background knowledge. And so oftentimes I will maybe be slightly more empowered than the average patient to kind of say, or what about this therapy, or I've heard about this particular thing. I've read a study that said X, Y, or Z, and oftentimes it does delve. There's a very difficult line to walk, I think, as physicians, between pharmaceutical therapies and non-pharmaceutical therapies, because clearly some people get benefit from things that are physical. So take, for instance, my Raynaud's. On the one hand, you would, as a standard, treat as a baseline with nifedipine, a blood pressure medication or a blood pressure lowering medication that comes with the consequence of flushing, which helps with the blood supply to my hands. But then there is also the non-pharmacological side, which is actually treatment with infrared therapy, and infrared's ability to improve circulation and vascularity in general. And there are actually some decent studies out there, which the beauty of Raynaud's is everyone has two hands. So if you design your study well, you can treat one hand, or you can basically treat for a period of time with medication and then switch to the other therapy in the same person. And actually infrared therapy has been shown to shorten that reperfusion time, which, for someone like me who was worried about, if I'm sat on the bike, and this is not anecdote, this is true, sat on the bike for an hour with a heart rate of 180 plus, doing hard intervals, it's hard to imagine that dropping my blood pressure because of my Raynaud's is not going to have a consequence at that point, because you run in really sort of tight lines in terms of your physiology. It's really quite common at that point to kind of have a slightly reduced kind of cognitive ability and those kind of things. And small changes in blood pressure might have a big influence, which is part of my personal anxiety about using nifedipine while I'm training. So effectively, you've got this situation where you've got someone like me who shows up and asks all these weird questions about things that maybe have at least some evidence base to them, that are not part of this kind of standard algorithm. You're never going to find them in a nice guideline or something like that, or national recommendations. So I guess I present something of a challenge in that way, in terms of trying to think of adjuncts to my therapy to kind of make my symptoms better. And I actually have an infrared light for that reason, although actually one of the biggest issues with it is fitting it into your day, because you need to spend 20 minutes under the lamp, and time and sleep time is actually kind of important. So that's actually my bigger issue with it, rather than whether it works or not, because it does actually work for me, and I'll keep it at that. And then I guess the other side of the coin is the kind of being able to empathize aspect. And I guess that was why I spoke about that young lady who I've looked after recently, because effectively, I think in many other instances, there may not have been quite the appreciation of what those sort of what I refer to as self-facing antibodies are really capable of, because much of the medical focus was at the time on whether there was a degree of heart block or not, which is a real thing to look for, but it's actually relatively uncommon. I'm pretty well versed in looking at babies, particularly in this kind of area, and I've only ever really come across one case where it's actually happened. And this has been over a number of years in a number of different places. So it's not that it doesn't happen, but it happens relatively infrequently. Whereas actually, I found far more commonly a degree of placental failure. And the problem with placental failure is that you get this spectrum. So some babies are considered small, they're below the 10th centile. So if you put every baby at 32 weeks and their measurements in a row, they would be child number 10 or less, and they're the easy ones to spot. The harder babies to spot are the babies in that 10th to 90th bracket who biologically wanted to be on the 80th centile, and when you see them, they're on the 30th, because actually there's still a process going on there that is causing this baby to be smaller, but is not technically small. So I guess it's helped in that aspect. And it's also helped to really kind of get it in my head that, you know, there will be antibodies that I don't know about. There will be sort of crossing in the placenta or effects directly on the placenta related to all of that. And I guess the other point is that whole vigilance piece about when to use steroids in pregnancy or not, which boils down to a clinical decision, but ultimately it's being sensitive about asking about joint swelling, about asking about any new skin lesions or new light sensitivities, or just not feeling well in yourself, and having the kind of wherewithal to say, well, this woman maybe should have her, you know, markers for inflammation and everything else rechecked, just to kind of see where her disease state is. So I guess it has been useful. The other side of the coin, I guess, is also to do with the pregnancy loss aspect, because one of the crossovers with lupus itself is actually another condition called antiphospholipid syndrome, which isn't the same, but it is actually really, really common in women with lupus, that they will also have these antibodies that will make them prone to blood clots, that will make them prone to either stillbirth or miscarriage. And again, it's having that background idea that actually, you know, when you see them to go through that first consultation, have they had those antibodies screened for? Do they have a degree of antiphospholipid living alongside their lupus? And should we be talking about thinning their blood as another mechanism to try and circumvent some of the consequences that can come about?
And briefly, and also perhaps Dr. George and Dr. Cooper can come in on this from their perspective. What advice would you give as a patient to others who have a different kind of opinion on the diagnosis or management plan? And then from the doctor perspective, what advice would you give to doctors who are dealing with that situation?
I'll maybe just take the easy route and stick to the patient aspect, which is ultimately, well, I think one of the best things I've ever personally done is just be really clear about what my story is, whether that's because I've kept a diary of my symptoms, or you know, so that, and also at the same time keeping a track of what therapies I'm on, what's new, when did I last have blood tests, did I know what those results of those blood tests were, you know, in terms of trying to keep an idea of what my personal baseline is. I take the instance with the kidney failure, for instance. So, you know, I knew that my kind of baseline creatinine, which is the sort of marker that we use for kidney function, was in the order of 70 to 80. So when I had a 125 show up, I knew that that was a change for me. And then they said, you know, you're a relatively muscular guy, maybe this is a variant of normal. But actually, I stopped the hydroxychloroquine at that point to see what it would do to the numbers. And of course, it came back down again. And then I said, right, well, is that true or is that false? You know, is that actually a causative relationship or not? And I think that's the difficulty for the doctor who looks after me, because I'm quite keen on actually keeping my finger on the pulse and, you know, making sure that I'm keeping an eye on myself as well as them, and keeping abreast with what's new, what changes are going on, and those sorts of things, and tweaking things. So I'm fortunate that I'm not on a systemic therapy. And I think if I was on a systemic therapy, I would have been far more reluctant to take that away, because I think if it had been, you know, I was on azathioprine or something like that, that was actually modifying the disease, I would have been more prone to say, look, let me pick up the phone, let me call my consultant and say, you know, here's the list of side effects I seem to be experiencing 4, 5, and 7. Is there anything that we can do about that? Because at that point, it's changing my disease. Whereas for me, I knew that the hydroxychloroquine wasn't really doing anything for me.
And Dr. George or Dr. Cooper, from your perspective as doctors, what would you advise other doctors with regards to managing the situation of a patient having, you know, different opinions or perspectives on their disease or management?
Shall I go as he's muted? Yeah, so it's always difficult, and you have to listen to your patient. In some cases, the patient is right, and so you have to go along with that. And in some cases, you have to work to dispel beliefs that are wrong, because we have the evidence that those beliefs are wrong. And that's the difficult thing, changing someone's opinion. But I think, firstly, if you've got continuity of care, that's very important. So quite often what happens in the NHS is you see one registrar one week, and then the next time you come, you see a different registrar or an SHO, and then maybe you might be lucky to see a consultant on your third visit, and no one is joining the dots. And so that can make management very, very difficult. And those three people might actually say three different things to you, and then as a patient you go, well, which is right and what do I do? So I think continuity of care is very important. Listening to a patient is important. Support groups are useful as well. There's Lupus Foundation, Lupus UK, and they can sometimes help as well. I'd tell patients to avoid just going on the internet, because you can find what you believe on the internet. Okay?
You can. Whatever you put into that search engine,
you can find it
get
there.
something back.
So that's the way I'd approach it. But I think you have to listen to your patient, and if they're quite convinced it's X, have you got the time to try and convince them it's Y? X might be right, but you have to think about a way forward. And it might be that, okay, it is X, so let's try something else, or let's go down a different route and come to a mutual agreement.
Thank you. So we have another question here for either of yourself, Dr. George or Dr. Cooper. What would you say the most common presenting symptoms are? And especially for GPs, what should they be aware of? I know you touched on a few things in your slide. Main takeaways.
Well, okay, so I'll go first. So as this, my diagram with the person on there just shows that actually you can present with all sorts of things. The ones that would make you sit up are painful joints and the skin and Raynaud's. If you have those three, the Raynaud's and the painful joints and the skin, you're halfway there in terms of thinking, well, actually, this is likely to be something worth looking into. Someone presents with lethargy, it's very hard. It could be anything. Someone presents with depression, it could be very difficult. If you've got abdominal pain, it's very difficult. If you're short of breath, it's hard. But I'd say, joint pain, skin rash, Raynaud's, mouth ulcers I didn't mention. It was on the list, but mouth ulcers, if you've got those as well, then you have to start thinking, well, okay, what's going on here? Particularly adult onset Raynaud's, as I mentioned before. The adult onset Raynaud's points towards secondary Raynaud's, which means there's an underlying condition. It doesn't mean that you got Raynaud's coming on as a child or teenager. That doesn't mean it's not a tissue disease, but it's more likely to be or an autoimmune rheumatic disease if it's adult onset.
And Dr. Cooper, do you have anything to add to that?
Well, I would say that as far as daily concerned, we get a lot of referrals of people with patchy hair loss. And that's why it's important. A lot of GPs like to blame fungi for everything. And they're quick to give antifungals without, examining the patient's scalp properly and so on. And, I would say the commonest thing to give you patchy hair loss in the scalp is Alopecia Areata, which is an autoimmune disease where you get very shine, just suddenly you see the shine. They said you can drop a 50p in the spot, shine patchy, which may be one or multiple patches. And this is usually self-limiting. So it's important to distinguish this from a fungal infection of the scalp or scarring alopecia, which can be caused by lupus, and lichen planus. That's another thing that can cause scarring the scalp. So it's very important, once you see a patch of hair loss which is not improving, to then refer to a dermatologist who can, carefully examine and do the necessary diagnostic test.
Okay. So I've got another question kind of linked to that for both of you. So by the time patients present or are referred to a dermatologist or rheumatologist, on average, how long has the delay been between the history of them first developing symptoms and visiting their GP and then finally being referred, from your experience? Dr. Cooper, would you like to start first?
It's really, you can't really tell, it's an individual, you can't really tell. Some people, at the first sign of any symptoms, they're at the doctor, and then other people can wait for years to present. So I don't think I can answer what time they present. It's just that I know the longer you stay with scarring alopecia, or with lupus in the scalp, the more likelihood there is of leaving permanent scarring and more extensive scarring.
And Dr. George?
Yeah, again, you can't really say, because again, I'll just refer you back to that diagram I had, and some of the symptoms are just so non-specific that it can go on for months, it can go on for years before somebody suddenly clicks and thinks, hang on a minute, what's going on here? Could this be systemic lupus? And on rare occasions, it might be that the patient turns up with organ failure of some sort, either kidney failure or usually the commonest one, or issues with their lungs, for example, pleurisy, pleurofusions. I didn't touch on antiphospholipid syndrome, but if you've got clots or recurrent clots, vasculitis, inflammation of blood vessels, once it gets to that sort of stage where major organs are affected, then people start to sit up. But the subtle symptoms, aching joints, feeling lethargic, maybe a bit low in mood, those are very hard, and they can go on for years, really, until something like a skin rash turns up, or an actual swollen joint, for example. Because you can have the aching joints or that swollen joints. So difficult to say how long, but yeah, that's probably the best I can say.
And I know, Mr. McPherson, I think you touched on this earlier, but someone's asked, how or can lupus cause miscarriage, and how common is that for patients who are pregnant with lupus?
So lupus directly, I'm not aware of causing miscarriage, but the challenge there is miscarriage happens to 1 in 4 pregnancies. Lupus occurs in 1 in 1,000 sort of adults. So effectively, you have a rare condition and a common endpoint. So it's very difficult to kind of prove what's sort of cause and effect. What we do know, however, is that there's a much closer association with poor pregnancy outcomes in relation to antiphospholipid syndrome, be that fetal growth restriction, late stillbirth, and pregnancy loss after 10 weeks. And I think that's part of why you see those features as part of the sort of diagnostic criteria for that aspect of the condition. So I think for women with SLE without evidence of antiphospholipid syndrome, I would put it to them that actually, the chances of running into a problem in the pregnancy in the first 12 weeks are probably at the moment not proven to be above the kind of background risk. Although clearly the sort of growth issues and so on and so forth later on are still a feature. And I think there's a separate category of women who know about antiphospholipid syndrome or who don't know about antiphospholipid syndrome, who go on to experience recurrent miscarriage, which is 3 or more consecutive miscarriages. antiphospholipid syndrome is thought to account for as many as 1 in 6 of those women. So you've got this much smaller cohort of women who are 1 in 100 of the sort of pregnant population, who are effectively the lion's share of the reasons that we can identify as to why they've been losing babies.
Thank you. Our next question is directed towards Dr. Cooper. So if you have discoid lupus and have only occasional or temporary breakouts, should you have regular checkups or not? How frequent would you say you should be having input from a specialist? Oh, sorry, you're on mute. Sorry, we can't hear you. There we go.
I treat it, I do it on an individual basis. If it's mild and topical steroid is keeping it under control, maybe every 6 months, maybe once a year. But then some people with active disease, you have to see them more often and then say, well, look, this topical steroid is not helping it. It's on your cheek. You know, you're going to get extensive scarring. I would like to try you on some oral medication. You know, a lot of people are reluctant to start oral medication. And so you have to convince them or try to convince them that they should try hydroxychloroquine. And then you monitor them. So those people like that, I would tend to see more frequently. And also I'd go on to at least once or twice a year, check their bloods to see if they maybe, because you can go on to develop systemic lupus. So from time to time, I do check for that as well. So the frequency depends on the severity of the skin lesion.
As a minimum, you'd probably say at least yearly.
Yeah. Oh yes, definitely. I definitely follow them up. I tend not to discharge them.
Thank you. So next question is with regards to investigation. So what other markers should be checked if an ANA test is negative for SLE?
I presume that's directed at me.
Yeah.
Yeah. Okay, so the ANA is, this is a controversial thing. Is there such a thing as ANA negative lupus or seronegative lupus? And there's a big debate about it. There are other antibodies, which are the DNA, which is quite specific, but it's rare to get positive DNA antibodies in the absence of ANA antibodies, but it does happen sometimes. That's first thing. And then there are the ENA, or extractable nuclear antigens, and there's a long list of them, SM, RMP, ROLA, or SSA, SSB. Now, again, it's unusual to have positive ENA antibodies in the absence of a positive ANA test. So that's why we usually do the ANA as the screening. And if it's positive, then you go on and usually, depending on where you are, sometimes the lab does it automatically. They check the DNA or ENA. Okay, having said that, there are other features you look out for. So Dr. McPherson mentioned low white count. So neutropenia, so low neutrophils. Lymphopenia, so low lymphocytes, usually a level below 1, is another feature. And then there's complement. If you've got active lupus, systemic lupus I'm talking about, complement may be low. So that's the C3 and the C4. So if you've got features of lupus and you've got low C3, C4, for example, and you've got lymphopenia or and an anemia as well, you can sometimes get a thrombocytopenia, so low platelets. So if you've got all those things and you've got clinical features, then you know you've got to have a high suspicion for lupus. But I think the main stay of treatment or of investigation is the ANA antibody. But there are other things we can look at. I mean, I saw a patient this week who was similar. She had butterfly rash and had a few symptoms, but her ANA was negative. But then she had normal inflammatory markers. C3, C4 and lymphocytes, but she's definitely photosensitive. So yeah.
Thank you. And given that obviously it's not always quite straightforward with all of these investigations and getting a diagnosis, somebody has asked, what should they do if they're concerned about lupus and having a lot of symptoms, but their GP has done some tests and, they're not really that concerned? What would you suggest that person do?
Well, I think obviously it depends on the symptoms they've got, and sometimes you could just say, well, look, at least let me see a rheumatologist. At the moment, depending where you live, there's a long way to see a rheumatologist. But under normal circumstances, blame COVID. If under normal circumstances, you can say, well, look, I've got all the symptoms. Can I at least see a rheumatologist? They can refer you on.
Thank you. And this is a question for both yourself, Dr. George and Dr. Cooper. So given how, general and non-specific lupus symptoms can be, if somebody has a relative or family history of lupus, how low should the threshold be for investigating further, or is that not really something to be concerned about?
So there is a genetic predisposition. It's not what we call a Mendelian inheritance. By genetic predisposition, I mean there is a higher chance if there's a first-degree family member with lupus of you having lupus. So you have to have a higher level of suspicion. So yes, if you're presenting with symptoms, then get investigated.
Thank you. So Dr. Cooper, so this is a question. I've heard that discoid lupus can transition to SLE. What can one do to lessen the chances of this happening, if anything? And how would one know if it is happening?
I don't know if you have any control over any control over of it switching over or going on to. That's why I think it's important to see the patient regularly. And if they develop systemic symptoms, which suggests that they may have more severe disease, then you do the necessary investigations. And if the markers point to it, then you refer them on to the rheumatologist. So I think careful monitoring of your discoid lupus patients who get symptoms other than that of the rash on the skin, joint pains or lethargy, or on the routine blood tests, neutropenia or something like that, then you know that you need to refer them onward. Careful monitoring is very important.
And with regards to that monitoring, somebody has asked, should that burden be mainly on a GP or mainly on the dermatologist? And what would a dermatologist expect from a GP in terms of, initial investigations and ongoing management?
Well, if they present with the skin rash and the GP cannot decide what it is and has a degree of suspicion and is referred, and then I said, okay, this person has discoid lupus after doing the biopsy, then I could put them on topical steroids, and if that's helping, I may say to the GP, just continue repeating the medication for them until I see them in 6 months or in 9 months. And then when they come back to you, if there's symptoms that suggest more involvement, systemic involvement, then you do the necessary investigation. So I don't normally put a lot of pressure on the GP. The hardest thing for me is to get them to refer the patient to get the correct diagnosis and then get the proper treatment.
Thank you. And a question for either yourself or Dr. George. Are eosinophils or eosinophilia important markers in the blood when suspecting SLE or DLE?
Dr. George.
So the eosinophils are not, no. Eosinophilia is more common in a condition called Church-Strauss syndrome, which has changed its name to eosinophilic granulomatosis with polyangiitis. They've made it nice and long just so we can feel special. So no, the eosinophils aren't an important marker in this. No.
Thank you. And for Mr. McPherson, do you think that being a doctor made your journey harder or easier?
I suspect it foreshortened it. So I think had I not kind of walked through the door saying, look, I think there's a degree of this, if it's not, you know, explained by an infection or something else, and I think there's more to it. You know, and I guess ultimately probably what took me away from the diagnosis was having the anti-centromere antibody. That made it kind of less clear cut for others, but ultimately, because I was able to have that conversation with my doctors at the time, I suspect it was probably a lot easier to kind of say, look, this is what inherently I'm concerned about for these reasons, which I think if you're not from a medical background, you've never heard of lupus and the difference between lupus and antiphospholipid syndrome versus mixed connective tissue disorder versus you know, systemic sclerosis, is very difficult as a patient to say, look, I just don't feel well. Come back with a few results that don't really draw together an obvious conclusion and then kind of go from there.
Mm-hmm. Thank you. So a question for all of you, maybe controversial or not, who knows. Do you recommend a person with lupus to take the COVID vaccine?
I've already had it.
You've had it. Mm-hmm.
I'd say yes. Yeah. Because of course, you know, if you've got lupus, your immune system is not as strong as it should be. So you want to give yourself the best chance. As I said, you know, lupus can, the whole thing about COVID is people with underlying conditions are the ones who are faring not so well. So you want to give yourself the best chance. So yes, do have the COVID vaccine. I've had both. My antibodies have probably run out now because it was December, January I had them, but probably need a booster now. But yeah, so yes is the answer. Yes, yes, yes.
Thank you.
I will just qualify that actually. Just bear in mind. But if you're on steroids, you know, your response is less good with the vaccine. But of course, then if you're on steroids and you have the virus, your response will be even worse. So yes, do have it even if you're on medication. That's the recommendation.
Just one other thing, it's somewhat kind of tongue-in-cheek from me, but I figured that it was probably about time that my immune system had something else to work on other than me, so I was quite happy to have the vaccine.
Thank you for that. So we've got a question here for Dr. George. Is reflux, GERD, and the like often present with lupus or scleroderma?
Yeah, scleroderma. I mentioned the crescent syndrome, probably more common in scleroderma because you get issues with motility of the gut, particularly the esophagus. So you can get reflux, and some people have difficulty swallowing as well. Yes, scleroderma, but also in lupus, if you're on non-steroidal anti-inflammatories, for example, then you know you like to get.
Thank you. And I have another question here. Can bones be affected to the point where they bend or curve?
If your bones are bending or curling, it's more likely you've got a condition called osteomalacia, which is not related to osteoporosis. And that's a severe vitamin D deficiency. Long term. In children, it's something called rickets. In adults, it's osteomalacia. So in lupus, the only way, if your spine curves, that's usually osteoporosis, and that's not spine itself curling, but the backbones, which are usually rectangular, wedging down, it's triangular, and they wedge down because of fractures. That's osteoporosis. Yeah, that's not to do with vitamin D deficiency on its own, but also other factors.
Thank you. So next question is for Dr. Cooper. So it goes, I've seen a lot of people talk about having more education for UK doctors on skin presentations in Black people. From your experience working in the UK and the Caribbean, is there a noticeable difference in the knowledge around discoid lupus in Black skin or dark skin tones, or is there less of a difference than for other skin problems?
I don't know if I'm in a position to answer that question because I don't know what other people see. But I think most, I think most dermatologists would know how to, I should hope, know how to diagnose lupus, and certainly in skin of color, because of the pigmentary change, it would make it obvious that something is not right, and that would help you to have more suspicion and point you to sending this person to be further investigation. Further investigated.
Okay, thank you. So the next question goes, are azathioprine or Imuran safer than prednisolone, and can it cause cancer?
Dr. George?
Azathioprine and Imuran are the same thing. Imuran's the sort of brand name, and it's an immunosuppressant. And it can lower your white cells. And usually what we do before we start it is we check, you should have a blood test called TPMT, because some people lack the enzyme that metabolizes or breaks down the azathioprine, and which means it can accumulate in your blood. And if it gets too high a level in your blood, then it can lower your white count, and that can cause issues with getting infections, etc. So azathioprine is better long term in terms of side effects if if you're doing the right dose, and the dose depends on your weight. So we usually use 2 to 3 milligrams per kilogram, or that's what we aim for. So it's better long term. There is a very slight risk of lymphoma with azathioprine. That's the only thing. Not that's something that I think most of us are aware of and we'd look out for.
But
Thank you.
may I add something here that people who are on renal dialysis who take immunosuppressants, they normally see the dermatologist at least once a year, because they also stand the chance of developing melanotic skin cancers. So that's something that I see from time to time.
Mm-hmm. So the next question for Mr. McPherson. So we know diet is quite significant with regards to managing your condition. So how do you manage your diet, and also is a vegan diet better for any reason or not?
I'm glad you've asked me this question. The short answer is the best diet for lupus is a diet that doesn't contain lots of processed food. And I think that should be the beginning, the middle, and the end of that discussion. I say this as someone who subscribes to a degree of low carb, but actually that is for a combination of reasons. I've got a family history of type 2 diabetes on both sides of my family, and additionally I have a degree of irritable bowel, which seems to be most set off by gluten-based things. So for me personally, having spent a while charting what my food is, what the kind of health implications are, because actually I get quite sensitive teeth as well, so foods that are kind of high glycemic index, so in other words they turn to sugar really quickly, also kind of have a negative effect on my teeth. So for me personally, low carb-ish has kind of been helpful. It's been very, very damaging to my sporting endeavors, actually, because effectively you get a lot of energy from fat-based diets in a very slow manner. So when you want to go quickly, it's a challenge. And equally, the argument about vegan or not vegan, should be ethical in my mind, because I think if you are of the opinion that the way that food is produced, particularly when it comes to animals, is kind of morally right or wrong, then by all means do what is right according to your own sort of ethical and moral standpoints. But actually, if the question is purely scientific, actually what you find is that the single diet that seems to perform the worst at almost all health metrics is the standard American diet. So high fat, high sugar seems to create sort of rapid weight gain, B, tends to also have kind of quite damaging metabolic and cardiovascular results, and C, even in the group of patients with lupus, actually you find a lot of times that there are certain dietary triggers that seem to be related to mass-produced food. So you'll find that some people will speak quite openly about MSG containing foods and the result of flares. You'll find other people who are particularly nitrite sensitive. So those who've eaten meats that are dyed red will again have some issues that way. Diet is an absolute minefield, both in terms of the science that's produced and also in terms of the political persuasions one way or another. I think as far as the individual is concerned, number one, be governed by your own sort of morality. So I try to source sort of ethically sourced meat-based products because that suits my personality more than anything else. I think it makes sense to avoid sort of preservatives and so on and so forth. So most of my foods are home cooked. And I personally think that that is a big part of why I have not had an extension of my symptoms. As to what the trigger was, you know, was it the fact that I cycled near the back of a bus, or was it because I drank coffee that was instant coffee and had something in it, or, you know, who knows? The simple truth is that, you know, we ultimately are exposed to too many things to try and attribute a single point of, oh, well, it's because I eat red meat and red meat is bad. No food is necessarily bad. Unfortunately, some foods are addictive. And on top of that, particularly when you're talking about mass-produced foods, a lot of the times the content has nothing to do with nutritional value, has either to do with sellability or the ability to preserve. And so for those reasons, I personally take the standpoint that actually do what seems right for you, but also try to take away from some of those things in your diet that aren't necessarily necessary. And anything beyond that, you can keep a diary. You can see that if I respond poorly to nightshade, so every time I eat a red pepper or an aubergine, you know, I end up with a flare within the next 48 hours. Well, then, you know, I mean, that's a pretty extreme example, but ultimately that would be you. That wouldn't be everyone across the board.
And Dr. George and Dr. Cooper, would you like to come in on the answers to that question, or not?
I think he said it all. But the diet you recommend is good for every disease, literally, to keep us healthy.
Yeah.
So
I don't really have much to say. You know, have a healthy, balanced diet and keep active. I think that's what I put in my presentation.
General advice for everyone.
Yeah.
Perfect. So the next question.
Just going to say that actually the activity point is actually far more pertinent there, because again, if you're thinking about Raynaud's and that sort of thing, then actually what I've personally found is actually when I do more strength-based work and I use my upper body, actually my perfusion to my hands is better. When I'm cycling, actually my perfusion to my feet is better. So actually specifically on the point of, you know, trying to modify your disease, particularly if you're looking at chronic pain and joint pain and those sorts of things, there's really high quality evidence showing that actually use of exercise as a treatment modality actually does change disease course and does actually make symptoms more tolerable.
Thank you. So the next question is a sensitive one. But someone just wants to clarify, does lupus affect life expectancy, or does it depend more on which organs the particular person's lupus affects?
So if you read the textbooks, it talks about a reduced life expectancy with lupus. But as I mentioned before, lupus presents in lots of different ways, and treatments have improved a lot, and it all depends on which organs are affected. So it's, in general, there is a slightly lower life expectancy, but as I say, it's such a diverse disease, and can present in, you know, flares, and it depends on where you are and what sort of treatment you get and how early your organ involvement is picked up so that you receive the right treatment. Life expectancy has improved greatly. As I say, belimumab is an anti-B cell, B lymphocyte treatment, which is an autoantibody, it's a biologic, that works very well. Infliximab has some effects as well, and then, you know, the combination of, you know, azathioprine, tacrolimus. There's so many different treatments now that actually, you know, the life expectancy has improved greatly. Yeah.
Thank you. So with regards to kind of the general age range, is SLE more likely to present at any particular age over others, or not?
So it's usually in women of childbearing age. So we're talking, you know, 16 to 55. But you can get older people presenting with it, and you can get lupus in men, and you can get children. But in terms of how common, it's usually in that sort of age range. What was the second part of the question?
No, that was it.
That was it. Yeah. So and then there is another thing, which is about the antibodies. So things like the ANA antibody, the older you get, the more likely you are to have ANA antibodies present. But that doesn't necessarily mean you've got lupus. So if you do an ANA in a 70-year-old, you're more likely to find ANA antibodies present, but not lupus. So it begs the question, well, what is the ANA antibody doing? But yeah, so I think you have to go on clinical presentation rather than just on blood tests.
Because following on from that, there was a question that was asking how, you know, strongly is the predictive factor for someone who's ANA positive going on later to then have lupus?
So the ANA is quite non-specific, and there's a lot of conditions in which you can find the ANA being present. So ANA, having a positive ANA is not equivalent to a diagnosis of lupus. And then there are various titers of ANA. So the weak positive, we generally deem that to be negative. So that's a titer of sort of 1 in 80, in some labs 1 in 160. Medium positive and strong positive then has a higher predictive value of an autoimmune condition going on, the most common of which is likely to be lupus. But as I say, there are other conditions that you can have positive ANA. For example, if you've got positive thyroid antibodies, you can have a positive ANA. And that's why we look for other antibodies, the DNA antibodies and the ENA, intractable nuclear antigens, for more evidence, and then you do complement, low neutrophils, lymphocytes, etc. So just having an ANA doesn't give you a diagnosis. If you've got it, then you've got to be more vigilant. And again, that depends on the titer and the presenting symptoms. So I would hope that people aren't just testing an ANA for the sake of testing an ANA. So you can use it as a screening tool. It's not a screening tool. So you'd only do it if someone presents to you. You know, they say they've got a skin rash, they're lethargic, and they've got Raynaud's, and they've got arthralgia, and you do an ANA, then the positive predictive value is higher. If you just do it as a case of, well, we're going to do a population screen, then it's not very helpful.
Thank you. We've got a question here as well. So basically, Dr. George, you mentioned that SLE is 2 to 3 times more common in Black people compared to Caucasians.
Yeah.
Is this a comment on the world, or is this something that's a comment on obviously us here in the West and the diaspora?
Yeah, no, so the answer is where the diagnostic facilities and medical facilities are available, then it is worldwide. So if you get African Americans have a higher incidence than Caucasian Americans. And now in Africa itself, my origins are African. I'm an imposter in this group.
There's no imposters. It's fun. Everyone's welcome.
Where you know people might be said that they're mad, for example, but actually, in fact, what they've got is a psychosis related to lupus. And so you do find that there is an incident there that is just not picked up. So you don't have the evidence. But when you do test it, you know, when people do present, then you do find it actually is there.
And quickly, just to follow up, what is the prevalence in people who are Asian or from Middle Eastern descent?
I don't know the answer to that question, really, but they do have it. I did an elective in Malaysia many years ago, and a friend of mine worked in Singapore, and he said, you know, he just treated lots of lupus in Singapore. So, and if you look at the literature, you know, the Chinese present lupus patients, lupus papers rather, and you know, people from Hong Kong, China, so it is there, but I don't know what it is in terms of prevalence.
Thank you ever so much. So just because we're now just past 8, I'm just going to have to wrap everything up. Thank you so much, all of you, for your contribution to the event, and we all, I'm sure, appreciated your input and your insights and your experience. I'd also like to thank everybody else who's been watching. We've had some really brilliant questions, and it's nice to see everybody engaging and you know, finding ways of finding out even more on such an expansive topic. So I would like to ask everyone to please follow BCGG on Instagram, Twitter, LinkedIn, and Facebook as well. And yeah, do take this away, the knowledge that you've got, and you know, spread it with your family and your friends. If there are any other questions that you have, do feel free to pop it in the chat, and we can figure out a way of properly forwarding them. And somebody, I think, has just asked a question with regards to the recording of this. I believe it will be shared, I think, on a YouTube channel that we're developing. So do watch the space, and you'll be able to share that as well. Okay. So any final thoughts from the 3 of you? Any key takeaways that you'd like to share before we end?
Just to say thank you very much for inviting us along. You know, if you've got symptoms, get them checked out.
Thank you. Mr. McPherson?
I would just like to echo the sentiment that actually this has been really, I think, really helpful to be a part of, just as a participant, let alone for those who've kind of heard from us. And so just thank you for running the event. I guess the only other thing is just, I guess it's worth remembering that there are specific implications for pregnancy. I'm always going to bang the pregnancy drum. And, you know, these women often represent either innocuous nothing happens, or actually some really significant things. So I think it's worth just remembering that these are young women of reproductive age, and when you're faced with a question like lupus, it's also worth thinking what would happen if she was pregnant.
And Dr. Cooper, any final thoughts or
Well,
takeaways?
thanks for inviting me to be on this panel. I feel honored, and I've learned a lot myself, especially from Dr. McPherson and his own personal experience, both as a doctor and a patient. And you know, I said to my son, who is a GP, all the time that even though I've been practicing in excess of 42 years, that I learn every week, I learn things. And I also learned something on the program tonight about, you know, the way you look at disease and empathy to patients. So it was a good experience for me as well. And as I hope that we were able to impart some knowledge, share some knowledge to others.
Thank you ever so much. Thank you all once again, and thank you to everyone behind the scenes who have done a lot of work to make this event possible. So I hope you all have a wonderful rest of your evening. Good night.
Good night. Thank you.
Bye-bye.
Thank you. Good night.